A very good afternoon. I think it can be called afternoon or any change in English, because whenever I write any mail to Dr. Vivek Handa, he replies it back with corrections. So I don't know whether he'll do the corrections in the way time also or not. This year, when we thought of revamping all the orations, we scrapped off all the old orations and we kept only 4 orations, and this is one of the orations. The society was kind enough to accept the request of myself and my wife to start an oration in our name. And the first orator is none other than Dr. Vivek Handa. Vivek Handa, a great administrator, a former Deputy Joint Commissioner of ESI, and it was his vision to start medical colleges under ESI, and he personally supervised and the medical colleges at Kalaburgi and Faridabad. Currently, after his supervision from ESI, he has joined the medical college as adjunct professor. He is the former president of Geriatric Society of India also, and has been associated with the teaching programs of GSI. This time, he is delivering an oration entitled Geriatrics in India, Past into the Present. Over to you, sir.
Thank you, sir. Thank you, chairpersons. At the outset, I would like to say that, okay. Good morning, everybody. It's still a little while to the afternoon. And at the outset, I'd just like to say that I am humbled to be delivering this oration in the name of Dr. O.P. Sharma and Srimati Shanti Sharma. This is the general overview. I would like to give the general overview of geriatrics in India, past into the present. And thank you all of you for keeping your phones and mobiles in the silent mode. Now, geriatrics term was first coined by this gentleman, we are all aware, in the year 1909. He was an Austrian-American medical doctor and gerontologist. He said till that time, the elderly were treated like any other adult. So he said, no, they are different. And he published an article in the New York Medical Journal where he said that we need to coin the term geriatrics vis-a-vis like we have the term pediatrics for children. Now this term also draws from geronte, which was a group of men over 60 years of age in the elderly age group who ran the legislative council, the Gerousia in Athens. Coming to Britain, the development of this subject was in between the two world wars. And during this time, Britain reorganized their chronic hospitals, as they were called. And Dr. Marjorie Warren was given charge of one such hospital in 1935, where most of the patients were elderly. So based on their needs, she classified them into ambulatory patients, which were chronic up patients, then bed-bound patients who were continent and not continent, then senile patients who were not noisy and annoying and noisy or annoying. Now, based on her observations and principles by her team and colleagues, the British Geriatric Society advocated these principles, and they were incorporated into the NHS when it came into existence in July 1948. Now, the question often asked is, did India wake up very late to this problem or this emerging problem of geriatrics? Well, during this contemporary times of Nasher and Warren, India was facing a very different set of problems. There was an intense social upheaval for the continuing struggle for independence, and immediately after independence, you had a euphoric country which had emerged from the yoke of colonialism. But on the flip side, you had a very poorly structured health system, or again, the courtesy its colonial masters in the past, a socio-economic status which was beset with colonial plunder, and the country was in the stage where you had a high death rate, high birth rate, and fertility. The expectancy of life at birth, if you compare the three countries in the period 1945 to 50, India had just 32 to 35. That means the population was only expected to live up to this age. Whereas in USA and Britain, it was in the 60s. So, India, during this point in the contemporary times when Nasher and Warren, developed, or the specialty of geriatrics got established in the Western world, India had a very young population compared to the perigeriatric or a geriatric population in USA and Britain. So, with different population structure and dynamics, the health needs of the systems were different, and obviously different health systems emerged. Then the health expenditure as percentage of GDP in the immediate post-independence period, the priority public spending was in areas other than health. That has been quite consistent in the years following independence also. When it was just 0.22% of the GDP in 1951, it rose to about 1% from the years 1985-86 to 2015-16, and latest by 23-24 it has gone up to nearly 2%. Coming to the number of projected elderly in India, up till 2011 are the actual numbers. The figures have been rounded off, so they are basically broad estimates. From 2 crore population, it went up to about 10.4 crores in 2011, which was about around 8.5% of the total population. And the projections for 21 and 26 are, it will be about 13.6 crores, in 26 around 14.2 crores, which is between 10 and 11% of the total population. These are projections. So, we see that there is a fourfold increase from 1950 to 2011, 2.2 crores to around 7.7 crores. The number was still unitary as percentage of the total population, 7.4% in 2001. Now, at the turn of the century, in 1999, the first major policy initiative was taken by the Government of India when the Ministry of Social Justice and Empowerment announced the National Policy on Older Persons, or the NPOP. It is worthwhile to say that the life expectancy at that time at birth was around 61 years in India, which is comparable to the life expectancy when in the West, when Nasher and Warren, the specialty of geriatrics started in the Western world. This first policy document on the elderly, the goal of this document was, the framework included the well-being of older persons with an assurance that their concerns were national concerns. And the policy framework listed out state-supported action strategies in certain principal areas of intervention, which it was felt was required for the elderly. Secondly, this policy recognized the critical need for effective implementation. Now, these were the areas which were listed in the policy, which was financial security, had old age pension, sensitivity in taxation policies, rights of parents without means to be supported by their children, and so on and so forth. Shelter was another area of intervention where it was said that this is the way to go forward for ensuring shelter for the elderly. Healthcare and nutrition, this was another priority area which was envisaged under the policy, which said that there should be good affordable services subsidized for the poor, cross subsidy by having different user charges for different socioeconomic strata. There should be a judicious mix of comprehensive geriatric public health services with better administration and delivery systems. So it called for more efficient delivery systems and management of the resources. Health promotion to be provided and promoted by the state. Health services by not-for-profit, including trust and charities with some assistance and concessions by the state to complement the effort of the states. In effect, it said that the state will not be able to bear the load of complete services, and the rest of the systems had to complement the services to meet the challenge. This was back in 1999. And they talked of some private medical care regulation, preferably by association of care providers. Then it said of training and elderly orientation to paramedical and nursing care providers in primary, secondary, and tertiary healthcare settings. Health education, which would promote the concept of healthy aging, that is, inclusion of preventive and promotive services. Then providing information for families of older persons on caregiving, nutrition, balanced diet, disseminating programs on yoga, meditation, and other techniques to provide a holistic package for the elderly. Under this, presently, you have a national program for care of the elderly, which was launched in 2011. And a major expansion has been announced in September 2024, where all senior citizens aged 70 and above will receive health coverage regardless of their income. And the new key developments are a top-up coverage for a 70-year-old senior in a family which is already covered by Ayushman Bharat, and family coverage of up to 5 lakhs for a family which is not in the existing AB PMJ family. And here the senior will be provided a cover of 5 lakh on a family basis. So you have a situation where an existing family which is covered, the senior gets a top-up of 5 lakh, and a senior who is there in a family which was not a part of the system before, there the whole family benefits in terms of the coverage given. Then another area which was listed was education, where basically development of IEC material, removal of discrimination against older persons for accessing programs, CMEs directed at re-employment after superannuation, so on and so forth. A good part of this was that the policy said that schools should develop outreach programs for interaction of students with elders on regular basis. Welfare was another area where the main thrust would be you identify the most vulnerable, non-institutional services by NGOs to supplement government effort. You encourage them to establish daycare centers and outreach activities. Then recognize the need for plurality of welfare services. That means the state's efforts to be supplemented by the other stakeholders in the health system. There was also talk of setting up a corpus for welfare of the elderly. Where will the money come from? And they said the funding would be government, trust, corporates, and individuals who would receive tax rebates. In this context, a senior citizen welfare fund has been established. It is an interest-bearing account in the public account of Union of India. The funding into that account comes from unclaimed amounts in small savings of the central scheme, EPFO, PPF, life and non-life insurance schemes, and accounts of coal mines provident fund. Now, unclaimed accounts have been defined as accounts which are lying unclaimed for a period of 10 years or more. That is the basis. And it is administered by the Ministry of Social Justice and Empowerment by a committee which is headed by the Secretary to Government of India. Another area was protection of life and property. And this policy said there should be a legislation for protection against physical abuse and neglect by children, amongst other areas which were listed out. And under this, the Maintenance of Welfare of Patients and Senior Citizens Act 2007 was enacted. It was essentially for the provision of maintenance and welfare of old parents and senior citizens for making it more effective and making it legally binding for adult children and heirs to provide for parents by way of a monthly allowance, so that the parents could live a normal, comfortable life. Now, this act has been, an amendment bill to this act was introduced in the year 2019. And this amendment, it expands the scope of children, parents, welfare and maintenance, and recommendations to the Lok Sabha Standing Committee have been suitably incorporated in consultation with the Legislative Department. The NGO sector was another area which was deemed important, and it as an institutional mechanism which would complement state efforts through reduce intra and interstate disparity in their presence, increase networking, taking on manpower training program, support for volunteer program, advocating healthy aging, and so on and so forth. The policy recognized that the elderly were a potential source rather than a burden. It recognized the untapped potential of all 60 plus people and said that the contribution of the elderly in running the household was unsung, more so for the female elderly. It also said that the elderly have the capacity to transmit socio-cultural heritage to grandchildren, and said specially designed programs should be created for this. Research was another area which the policy recognized. The policy also said that the family is the most cherished, vital and informal social security for elderly in India. Despite the family systems going change, it still said that it is still the most cherished, vital and informal social security. And most importantly, it said it is an emotionally satisfying living arrangement. It envisaged to support the arrangement through, strengthening support services, promoting family welfare, recognition of the role of married daughters taking care of their parents, incentivizing children to cohabitate with parents. A part of the new extension of Ayushman services, it's one of the mechanisms to support this. And short-term stay facilities for elders to provide caregiving relief to the families. Then training of manpower was another area for intervention, in which they said doctors with MD courses in medical colleges, nursing curriculum in geriatric, community volunteers. Presently, the subject of geriatrics have been included in the MBBS curriculum in the CBME from the year 2018. MD programs you have in 18 NMC approved medical colleges with 48 seats. This is apart from the courses in MD geriatrics being run by various aims, because they do not come under the NMC. IGNOU runs a diploma program in geriatric medicine since 2004. Now, the Ministry of Social Justice and Empowerment has a national action plan for preparation of sufficient manpower of geriatric caregivers. Basically, 4 programs are there where you have geriatric caregiver in the health sector, both for institutional and home care, elderly caretaker and care companion, and wellness therapists for the elderly. The role of media was also recognized, where the media usually is believed that it actually sensationalizes an event. So rather than sensationalizing the elderly and promoting negative stereotype, it said that media should promote active aging, dispelling stereotypes and negative images, strengthening intergenerational bond, and providing information on aging process to families and communities. These were some other areas of action, miscellaneous. It recognizes the criticality of implementation for benefits to flow at ground level. For that, the Ministry of Social Justice and Empowerment was designated as the nodal ministry to coordinate all manners, with a separate bureau for senior citizens, an interministerial committee to coordinate efforts of various line ministries, preparation of 5-year and annual plans, setting up of an autonomous national council for older persons headed by the minister to promote and coordinate concerns of the elderly. The NCOP in this regard was reconstituted in the year 2012, and as per the information I could find, the third meeting of the council was held way back in 2018. Then they said that the nodal ministry would review the progress every 3 years, and it would encourage Panchayati Raj institutions to participate in the implementation of the policy by mobilizing the talent at local and village level. Village panchayats would be used for advocating different measures. So the framework was very well laid. From 99, we go on to the year 2001, which was a landmark year, because this was the last census was conducted in this, where the population was 8.6% or 10.4 crores. There was introduction of two documents. Introduction of two features. One was a policy document, which was the NPSC 2011, and a program which was the NPHCE. The National Policy for Senior Citizens in 2011, it built on the initiatives of NPOP 1999. The foundation was based on increasing numbers of elderly, changing socioeconomic status, technology, high levels of destitution amongst the elderly, rural poor, feminization of dependent elderly, changing morbidity patterns, and social deprivation. It valued an age-integrated society through strengthening and integration between generations, facilitating interaction between different age groups, and development of a dual system to enhance the capacity to care for their senior citizens at home. It focused on mainstreaming elderly senior women. It promoting the implementation of mechanisms already in place and preventive strategies for aging in place or aging in their own home with income security. It said that the care of the elderly to vest with the family, with the institutional care being the last resort. Working through a barrier-free society, financial security, assisted living facilities for abandoned elders, and more effective implementation of the Senior Citizens Act 2007 by setting up tribunals. It proposed some new intervention areas, which was raising the pension to 1,000 rupees under the Indira Gandhi National Old Age Pension Scheme under the Ministry of Rural Development, extending PDS public distribution system facilities to all BPL elderly, strengthening of elderly primary health care, where the ASHA was to conduct special health screening for all the citizens 80 plus. Then development of health insurance policies for all segment of elders, and 5-year tenure for the National Council for Senior Citizens, with establishment of similar bodies at state level, because health is a state subject. The NPHCE was a state-oriented program which was launched in 2011 with the basic thrust to provide dedicated healthcare services to senior citizens. The objective was to provide accessible, affordable, and high quality, long term, comprehensive, and dedicated services to an aging population, creating a new architecture for aging, building a framework to create an enabling environment for a society for all ages, to promote the concept of active and healthy aging. All this was that you need to have more preventive and promotive activities for the aging. And convergence of the NHM, Ayush, and other line departments like Ministry of Social Justice and Empowerment. It has a component which is the NHM component, which says you provide primary, secondary care delivery through district hospitals, CHCs, and PHCs, and a tertiary component to be provided through regional geriatric centers located at 19 medical colleges in 18 states of India, 2 national centers of aging at Ansari Nagar, AIIMS, and Madras Medical College, Chennai. In this regard, the NCA at AIIMS was inaugurated recently on 13/12/23 and at Madras Medical College on 24th September this year, 24th February this year. Foundation stone ceremony for another NCA at BHU was done on 23/2/24. This program has a component of research, which is called the LASI project, where the IIPS Mumbai is going to conduct a survey, the first part of which was done in 2017, covering 30 states and 6 union territories, in 4 subject domains. One was the health, healthcare and healthcare financing, then the social aspect and the economic aspect. The final report of LASI Wave 1 was released in the year 2021. It has interesting observation, but that's another topic. Now, the program strategies under the NPHC is it's a community-based primary healthcare approach, including domiciliary visits by trained health workers, dedicated health services at PHC, CHC level, district hospital, and strengthening of RGCs to provide dedicated tertiary medical facilities for the elderly. IEC using mass media, folk media, and other modes of communication to reach the target community, and continuous monitoring and independent evaluation of the program and research in geriatrics. So this monitoring and independent evaluation is a good. The expected outcomes are that you will establish a Department of Geriatric Medicine in the 19 selected medical colleges, PG courses in geriatric medicine, district geriatric units, OPDs, rehabilitation units, health welfare centers and sub-centers to provide equipment for community outreach services and training of human resources. Now, this is the level of package of services, where at the sub-center, the important is domiciliary visit for the care to homebound bedridden elderly and providing caretaker and training and support. A weekly geriatric clinic run by the trained medical officer, amongst other things, at the PHC level. At the CHC level, the geriatric clinic frequency goes for twice a week, from once a week at the PHC. District hospital having a dedicated OPD services for the elderly on a regular basis, lab investigation, and a 10-bedded geriatric ward for inpatient care of the elderly. The RGC having a geriatric clinic, which is a specialized OPD for the elderly, with a 30-bedded geriatric ward for inpatient care. Coming to the NCAs, OPD in various clinical disciplines, special clinics, daycare center, inpatient care, developing evidence-based treatment protocols, and special focus on care for 75% plus aged population. So this is the status of services up to 22-23. The government, for some reason, best known, in 23-24, they changed the format of reporting. So up till 22-23, you had sanctioned, you have 19 RGCs, 725 district hospitals, 4,888 CHCs out of 6,359, and so on and so forth. And the operational ones are on the right side. You have OPDs in 18 of the 19 RGCs, 640 of the 725 district hospitals, around 3,500 CHCs out of, say, about 4,900 CHCs, around 11.5 thousand PHCs out of the sanctioned 18.5 thousand around, and around 14 and a half sub-centers have the facilities against the sanction, 91,000 odd sub-centers. We have indoor wards, physiotherapy services, and that's the data. Now, the question arises, have we done enough? And is the government doing enough? In my opinion, it's the status of services is a work in progress, and hopefully it will increase. It's just a question of seeing the glass as half full or half empty. If you see it as half full, the choice is again yours. If you see it as half empty, again, it's your perspective. But the question is that being work in progress, there is need for more services. And the question we should be asking as the interface of the health system, whether in the public or the private domain, that what can I do? What can be my contribution? To my mind, the first and the foremost is that listen to your elderly patients. Doctors, I think today have forgotten the art of listening. Listen to their verbal communication, listen and observe their non-verbal cues. That's very important because half the time the elderly will not speak, but their body language will give you so much information. That's just amazing. You just have to try it. Treatment apart, you counsel them on various mechanisms, provisions, and institutions available for their better health and welfare. Make them aware so that the family and the elderly can access the available services. You may argue the available services are not sufficient, but accessing the currently available services will go a long way. And believe me, this small little effort will create at each of our levels will create a ripple effect which will transform into a giant wave in times to come. Thank you for a patient listening. Thank you.
Thank you so much, Dr. Handa. It's a masterly presentation. And you have given us in total the picture of the geriatric care development by Government of India. Especially the data from the document which has been released by Niti Aayog. You have covered everything. And I'm so happy that you have ultimately ended it on a happy note that yes, things are being done. Things are being done, and you have raised the question in our mind that what are we contributing for it? That's a wonderful thing. I think he deserves a big hand.